On this channel, we explore concepts and clinical reasoning in medicine in a simple and systematic way. Let's get started. Now we will discuss about GLP-1 receptor agonists in diabetic nephropathy. Glucagon-like peptide 1 receptor agonists have become an increasingly important therapeutic option in patients with type 2 diabetes mellitus and diabetic nephropathy. Although initially developed for glycemic control, accumulating evidence demonstrates that GLP-1 receptor agonists also provide significant cardiovascular and renal benefits. In patients with diabetic kidney disease, these agents help reduce albuminuria, improve metabolic parameters, promote weight loss, and lower cardiovascular risk, making them valuable adjuncts to renoprotective therapies such as renin-angiotensin system inhibitors and SGLT2 inhibitors. GLP-1 receptor agonists mimic the action of endogenous glucagon-like peptide 1, an incretin hormone secreted by intestinal L cells after food intake. In diabetic nephropathy, their benefits extend beyond glucose lowering. Experimental and clinical studies suggest that GLP-1 receptor agonists reduce oxidative stress, inflammation, endothelial dysfunction, and renal fibrosis, all of which contribute to progression of diabetic kidney disease. Several GLP-1 receptor agonists are commonly used in clinical practice. Semaglutide is available as a subcutaneous injection starting at 0.25 milligrams once weekly for 4 weeks, then increased to 0.5 milligrams weekly with possible escalation to 1 milligram or 2 milligrams weekly depending on glycemic needs and tolerability. Dulaglutide is administered once weekly beginning at 0.75 milligrams, with escalation to 1.5 milligrams, 3 milligrams, or 4.5 milligrams weekly. Oral semaglutide is initiated at 3 milligrams daily and gradually increased to 7 milligrams or 14 milligrams daily. Liraglutide is started at 0.6 milligrams daily for 1 week, increased to 1.2 milligrams daily, and may be titrated to 1.8 milligrams daily. Exenatide and lixisenatide are additional agents, although they are less commonly used in advanced CKD because of renal clearance considerations. GLP-1 receptor agonists can generally be used safely in patients with chronic kidney disease. Semaglutide, dulaglutide, and liraglutide do not usually require dose adjustment across most CKD stages, including moderate to severe renal impairment. Current evidence supports their use down to eGFR levels below 30 milliliters per minute, 1.73 square meters. Although clinical monitoring is recommended in advanced CKD because gastrointestinal side effects may increase dehydration risk. In contrast, exenatide is generally not recommended when eGFR is below 30 milliliters per minute, 1.73 square meters, because reduced clearance may increase toxicity. One of the major renal benefits of GLP-1 receptor agonists is reduction in albuminuria. Clinical trials such as LEADER, SUSTAIN-6, REWIND, and FLOW demonstrated reductions in progression of albuminuria and slower decline in renal function. These agents primarily reduce macroalbuminuria progression rather than directly preventing dialysis initiation, although newer data suggest broader nephroprotective effects. The FLOW trial involving semaglutide demonstrated significant reduction in composite kidney outcomes in patients with diabetic CKD. GLP-1 receptor agonists also provide substantial cardiovascular protection. Major trials consistently demonstrated reductions in major adverse cardiovascular events, including cardiovascular death, myocardial infarction, and stroke. Cardiovascular risk reduction is particularly important in diabetic nephropathy because cardiovascular disease remains the leading cause of mortality in CKD patients. The most common adverse effects of GLP-1 receptor agonists are gastrointestinal. Nausea occurs in approximately 15 to 40% of patients, especially during early dose escalation. Vomiting occurs in approximately 5 to 15%, while diarrhea affects approximately 10 to 20% of users. Constipation and abdominal discomfort are also relatively common. These symptoms are usually transient and improve over time. Gradual dose titration significantly improves tolerability. Weight loss is one of the beneficial effects of GLP-1 receptor agonists. Average body weight reduction ranges from approximately 3 to 7 kilograms with standard diabetic dosing, while higher obesity treatment doses may produce even greater reductions. Weight loss contributes to improved insulin sensitivity, blood pressure control, and reduction of metabolic stress on the kidneys. Hypoglycemia risk with GLP-1 receptor agonists alone is generally low, usually below 1 to 3%, because insulin secretion remains glucose dependent. However, hypoglycemia risk increases substantially when combined with insulin or sulfonylureas. Dose adjustment of concurrent insulin or sulfonylurea therapy may therefore be necessary. Acute pancreatitis is a rare but important adverse effect. Reported incidence is generally below 0.3%, although causality remains debated. Patients should be advised to seek medical attention if they develop severe persistent abdominal pain. GLP-1 receptor agonists are generally avoided in patients with prior pancreatitis history when possible. Gallbladder disease, including cholelithiasis and cholecystitis, may occur slightly more frequently with GLP-1 receptor agonists, particularly during rapid weight loss. Incidence in clinical studies is usually around 1 to 2%. Rare cases of acute kidney injury have also been reported, usually secondary to dehydration from severe nausea or vomiting rather than direct nephrotoxicity. An important safety consideration involves thyroid C-cell tumors observed in rodent studies. Although no definitive increase in medullary thyroid carcinoma has been proven in humans, GLP-1 receptor agonists are contraindicated in patients with personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasia syndrome type 2. Current ADA and KDIGO guidelines recommend GLP-1 receptor agonists in patients with type 2 diabetes and chronic kidney disease, particularly when additional glycemic control, weight reduction, or cardiovascular protection is needed despite standard therapy. In many patients, GLP-1 receptor agonists are used together with SGLT2 inhibitors because the two drug classes provide complementary metabolic, cardiovascular, and renal benefits. Overall, GLP-1 receptor agonists represent an important component of modern diabetic nephropathy management. Their ability to improve glycemic control, reduce albuminuria, promote weight loss, and lower cardiovascular risk makes them highly valuable in patients with diabetic kidney disease, particularly those with obesity, established cardiovascular disease, or persistent albuminuria despite conventional therapy. In the management of diabetic nephropathy, a physician must look beyond simply lowering blood glucose levels. The use of GLP-1 receptor agonists reminds us that true medical care is about protecting the patient's future, preserving kidney function, reducing cardiovascular risk, controlling body weight, and improving quality of life simultaneously. A good doctor does not wait for kidney failure to progress, but acts early with evidence-based therapy, compassionate education, and continuous monitoring. Through a comprehensive and patient-centered approach, GLP-1 therapy becomes not only a treatment for diabetes, but also a commitment to prolong healthier living and prevent the silent progression of chronic kidney disease. Thank you for following this discussion. In clinical practice, what matters is not just what we know, but how we think. See you in the next discussion.